AJ if he would go ahead and do that, or this afternoon. And I asked AJ if he would do that.
So listen up. Okay, I was asked to do this, and I was thinking of something. That,
Don't mumble.
I was thinking of just a topic like that I could do, and I chose this one because I think we all can relate to it in some way at one point in our lives. Getting even. So.
Don't be looking at me when he says that.
I grew up watching Major League Baseball. Over the years, there have been pitchers who intentionally threw at hitters, sometimes at their head. If a batter feared being hit in the head by a fastball, they wouldn't dig in the batter's box as firmly and would be much less effective as a hitter. It was a conscious decision by the pitcher to intimidate and gain an unfair advantage over the batter. The result often starts a war. I've seen batters charge the mound, ready to retaliate. Sometimes both teams would rush out on the field angry and ready for a fight. Once order was restored several innings later, a batter from the opposing team would often get hit by a pitch. The object was to get even or send a message. A hard foul in an early game in soccer often resulted in a retaliatory hard foul on the opposing team later. In both analogies, anger took precedence over self-control and became a premeditated attack on another person. How do you deal with your anger because of something done to you? Do you feel self-righteous? In reality, the person who feels they were wrong often gets the mistaken notion that they are better than the other person, that you are not as bad as they are. Now you want the other person to get what they deserve. Is that how God would like you to feel? Acts of retaliation are proof that you are a sinner too. You were just waiting for the right opportunity to get even. The retaliatory act of vengeance is feeling that you have a right to inflict pain or insult on the other. Even taking a non-violent approach by bragging, "I would never do that to someone else," is perceived by God being judgmental. Only God knows what is in the heart of each person, so He has the right to judge people. Since God is sinless, He can only truly say He would never do that. If a true wrong has been done to you, God will avenge it. You don't have to. The attitude of "I'll show him" just does just that. It shows God and everyone else that you are also a sinner, and you waste the energy spent defending your ego, your pride, and self-righteousness when you could have directed the effort towards solving the problem in a positive way. Handling the situation in a loving way achieves much different results. Love refuses to pay back and deliberately seeks to put the other person in the best light. It seeks to put their needs ahead of your own, all in the interest of helping the person change if possible. That is what God would want you to do. You can't stay angry with someone without feeling better than them. Fortunately, God doesn't seek to get even with us. Thankfully, He doesn't give us what we deserve. If God paid you back for what you have done to Him, what kind of life would you have had? And I tied this to something that I do in my own time. When a drunk has a terrific hangover because he drank heavily yesterday, he cannot live well today. But there is another kind of hangover which we all experience when we are drinking or not. That is the emotional hangover. The direct result of yesterday's and sometimes today's excesses of negative emotions, anger, fear, jealousy, and the like. If we would live serenely today and tomorrow, we would need to eliminate these hangovers. This doesn't mean we need to wander morbidly around in the past. It requires an admission and correction of errors now. So, that's my devotion. Do we have any prayer requests? No?
I do. Please, Lord, let me be swift and efficient so we're out of here before 6 p.m. Amen.
I have a meeting at 5.
I'm kidding.
Oh my God.
Okay.
You never know.
Okay, let's pray. pray. Dear Lord, we thank you for this day to be your hands and to help others. We ask that you take away our anger and that you take away our negative emotions so that we may better live to serve others and to serve you. We ask this in your name and we pray. In Jesus' name, amen.
Amen. Thank you. Okay, so you've been handed out a couple of pieces of paper. One of them, Barbara is asking that you sign this. Many of you may have done it, but it's messed up the dates because it has to be it's only good for 1 year from the date you sign it. So she's asking that you re-sign that. And it's in case somebody comes in and they're making a video clip and they want to videotape you working on a patient or whatever. Or if somebody comes in and starts taking photos because they're doing some publication, it's just allowing them to use a photo that you might be in. Whether it's the side or your back or whatever, you have to sign a consent.
They do not get these?
If somebody refuses to sign a consent, then at least write your name on the paper and you don't have to sign it, Barbara says, and then she'll talk with you later about
Do
it.
we date it with today's date?
Don't date it, she has the date.
It's highlighted. It's highlighted today.
It's highlighted.
Yeah,
I know.
She can white it out.
I have white out.
It was highlighted like, so right here.
Oh,
So I put the date there.
just put today's date then. Because you'll be gone by this time next year. Yay.
That makes you really sad, right?
And then you also have the sign-in sheet. So have you signed? AJ's already signed.
There's a lot of people missing.
I think you missed all the.
Okay. Also, a couple of things, I'm going to post some things, but Dr. Jewell says you need to tell them to sign up on the sign-up sheet. And I said, Dr. Jewell, I told them last week, I showed them photos, where it's found, what else. She goes, well, nobody seems to know. Why don't they sign up? So remember how I showed you the photos of where this sign-up sheet is for Dr. Jewell? Please use it. And then she said, what did she say? I can't remember, and she said, well, I'm going to start marking them off, and I said, okay, you can do that. So I gave that, whatever the announcements I gave last week, and it's posted online, she wants you to use those. Also, I posted an announcement regarding sealants. You will have a sealant lab coming up. You must have current x-rays, and you must have had a visual exam by Dr. Jewell before Monday, the 26th. So if you have free time, at some time, go over there and have Dr. Jewell screen you.
And if she screened us to get our x-rays done in the last 2 months, that's fine.
That's not
Not
screening.
fine.
This is screening for sealants specifically, because you're going to do sealants on one another. And she has to pick the teeth that you need to get sealed.
So, for example, if someone has lots of amalgam, so she doesn't need sealant, she's supposed to go again or no?
Go look,
Like me, 'cause I
because
don't have any tooth to do sealant. I have all amalgam.
every single tooth, premolars,
That's the other-
everything.
yes.
Okay, she
Just
might
like
be able to find like a buccal pit. She may be able to find something else, so still go for your screening. Okay?
And if somebody has extra that you get to share.
Yeah, you can bounce back and forth.
Okay.
She'll figure it out. Okay, and the last thing is, there's the Victorville block that was supposed to be for the 26th of this month, where you were gonna go to Victorville, have your orientation. Victorville messed up, and so there was a problem with all the paperwork that was supposed to be generated, because they need every kind of thing, identification, whatever, to go there, and it didn't get to us so that you could fill it out. So we are opening that day up as a clinic day. If you were scheduled in August, when it is, then you will come the 26th.
22nd.
22nd.
26th of August.
26th of August,
22nd,
22nd.
Which is Monday.
Monday. If you don't have a patient scheduled, you can book one Jeanette is also trying to find you patients as well really quickly. But if you know somebody that you might want to be able to bring in that day, go ahead and book it on that day. We're having less faculty and only 14 of you are on clinic and only one of you has a patient, but you must come. I just talked to Ms. Marshall and I said, let's just cancel it. She goes, no, they must be in clinic. So I said, okay. That's a good day for Dr. Jewell to screen you, if you have a moment to do that. Also, use it as clinic time. You can go to oral surgery, you can try to get an FMX comp, anything else, yes.
Could that be a good time to bring in our adult prophy patient to get?
Absolutely, yes.
So there's like enough faculty for that and everything?
Yeah, we'll be able to do that because you're just
And then we
working
can do
together.
like injections and stuff though?
Yes, if we have time. What happened was because it was scheduled as an off day, half the faculty already had plans. And so there's 4 of us, and I happen to be one of them that didn't have plans, so we have to come in. So I will be there, but there's other faculty that will be there too.
I just want to make sure the day that I have them come in, I can get like comps
That's our plan.
out of the way.
Because right now, nobody has a patient, so if you bring in a patient, we have 1 student that has a patient that day, and the rest of you don't, so. Okay, yes, Jessica.
So if we weren't scheduled for clinic on that August day, then we don't have to show up on Monday
You're
at all?
off.
Okay.
So we're actually swapping. If you had the 26th of August, you are scheduled for the 22nd of July. And if you are off, reverse. Okay? All right, any other questions? Okay, so please give Ms. Lennon your full attention. She is giving you the ins and outs of how to pass the OSCE exam. If you don't pass this exam, including remediation, you do not pass my class. Okay, you must pass your OSCE in order to pass my class. So give her your full attention.
So, junior competency exam, local anesthesia, was practice for this and was formative, meaning, how you doing? Are we up to speed? This is summative, this is it. So, don't freak out, but please take it very seriously and study for this, because I'll have to remediate people. It happens. It's okay. Happens every year. Just please try to make it few of you, okay? It'll be easier on all of us. Okay. Anybody else not have one of these guys? So, here's your cheat sheet. So this is,
Pass those things down the aisle here.
this is, I have to say, I think I've done really well learning an entirely new AAP classification system for the first time since 1999 and transmitting it to you. But I did have a couple little boo-boos that I found and now they're fixed. And I added some more detail. So this will be, take this in your bathroom while you brush your teeth and floss. Because this has to be in your head. By the OSCE.
And on the right, memorize it.
Got to be in your head. Okay, this is what clinic seminar looks like from your view. Yes?
Uh-huh.
Modules. I'm not sure I gave you enough information. It's daunting looking. Here's the thing. I know some people have trouble getting, when I post a document inside a PowerPoint, you have trouble getting it out of there. So remind me to show you how you can do that, at least with a PC. And then here is pretty much all the documents that are in the PowerPoint. So don't freak out that you have 400 billion pages to read, okay? But read it all from one version or the other. Okay. So. No. Okay, here's the deal. Our goal with the junior promotion OSCE is to assess whether you're on track in acquiring the knowledge, attitudes, judgment, and clinical skills needed to pass board exams and become a competent hygienist. Um, to identify areas that need review for all of you. So, just like on the quizzes, if you all fail one question, it's like, okay, that's probably me, not you. So, if we identify that everybody is struggling, or many people are struggling with a particular skill or issue, then we beef up our end of it. And we also want to know how you're doing too, of course. And then we're going to prepare you for the format of the National Board Written Exam and the State and Regional Board Clinical Exams. So, you have to do this skill within a certain time period. Here is a case you're going to look at. You're going to tell us what is your assessment of this patient and your treatment plan. And then for you to understand how far you've come this year. So hopefully your self-reflection in lab has been helpful, but I'm hoping that at the end of this you can look back and say, I started with no skills or very few skills maybe as an assistant, and I can actually safely set up a cubicle, assess vitals, talk about a health history, EOIO, a life-saving oral cancer screening, and safe and effective injections. So, that's the plan. So, we are Thursday, August 1st at 8 o'clock, we're actually starting at 7:45. This is all going to happen in one day. So, please come. Can we do something about those announcements? No? Okay, darn. We're doing the written portion in the morning and the clinical part in the afternoon. Eat your Wheaties and have a cup of coffee if you usually do. So this is a whole series of exams. The written part is going to take about 3 hours to complete. There is a MedComp patient interview. So that is the final capstone for Ms. Hayton's MedComp class. It's going to be in clinic. It's going to be about 20 minutes. You're going to have fabulous actors that are going to be your standardized patients. You're going to rotate in 2 groups. You'll be sequestered in our hygiene office. If you're not testing, we're going to swap you back and forth. There is a MedComp quiz. There is a pathology quiz as well that's in Exemplify. So you're going to have questions on MedComp, and most of them will be fill in the blank. And then you'll have pathology, common lesions, that you'll have pictures and a patient history. And you're going to tell me, what is this? Do you need a consult? Can you treat the patient?
Is that also fill in the blank?
I'll show you. So that's classroom 40 minutes, and then you're going to have that treatment planning of a standardized Axiom patient. And that is going to be in Nobel Lab. You're going to be able to sign into Axiom training. You're going to have a specific patient assigned to you, and you're going to tell me all the things, just like a case presentation on clinic about that patient. So, we are going to have, I actually put the schedule in this PowerPoint. You got to get here on time. If it takes 3 alarm clocks, if you have to stay at a friend's house the night before, you just got to be here, right? Don't start out in outer Mongolia. Be here. You're going to all show up at 1176. All your backpacks and your stuff, lockers. We don't have room for it. You're going to show up with your cell phone, or your smartwatch, and your laptop with the power cord. And you're going to drop that technology off on the phone jail and in the classroom at 7:45. You're then going to be escorted to your first assignment, because I have you split up in 4 groups, and you're going to be shuttled between different rooms. And we're trying to keep, academic integrity, not have anybody accidentally help each other by, whoops, I said that out loud. And so, then we're going to have these different test sites set up for you. That's what I meant. Yes.
Do we not have class on Thursday at 8?
It's canceled for this.
Oh.
Every year we do this
Scheduled.
instead. Okay, so here's how this works. You're going to be group 1, group 2, group 3, group 4. The 2 groups, 1 and 2, are going to be with me in the treatment planning exam in Nobel Lab first. Group 3 is going to be in 1176. Group 4 is going to be in MedComp up on clinic. And you guys will be done at about 8:40. You got 5 minutes to get there to the next thing. So these guys will switch places, and then we'll switch again at 9:25. Everybody moves, and so we can get everything done. Okay? So I will have your names on this list of where you're going to be. So see how it's treatment plan 8, Exemplify 8, MedComp 8. So whatever group you're in, you're just going to look at this part of the schedule. Okay? Clear as mud, right? Okay. So the MedComp and the PATH Exemplify tests. So really basic, significant concepts from MedComp course that impact patient safety. So what are the big scary things? That's what it's going to be about. High-risk patients, pre-med, and dental emergencies. And then intraoral findings, the commonly seen pathology and structures. You're going to tell me, do you need a path consult, and is the patient treatable? So tell me some common lesions that y'all have seen already on clinic. Linea alba. Irritation fibroma. Fissured tongue. Amalgam tattoo. Xerostomia. That's hard to do in a picture. Tori.
Herpes, recurrent aphthysis.
Herpes labialis. Fordyce granules. Aphthous ulcer.
Basal
No basal.
It's not on someone's face.
Basic stuff. Geographic tongue. Right? Juniors. You should be competent at telling me, do they have a herpetic lesion? Okay? Think about those lesions right now that we just talked about. Can you treat a patient if they show up with those lesions?
Yes.
Depends.
Sometimes.
Do you need a consult on any of those lesions? Think about that. Okay? That's what you're going to tell me. I have faith you don't think crazy things. I can't spell morsicatio, so it's not in there.
What would be a good way to kind of go over that stuff? We have so many detailed things.
The things we just said,
Just those things.
did someone write those down?
I got it recorded.
Get together after and say those things again, write them down. Okay. So, procedures that need pre-med. What are we doing pre-med for? When do we do it?
Total joint replacement, and they have like a heart valve.
Anything that causes bacteremia, right?
Okay.
So we have to be doing something that we're fishing around in the pocket. Okay, so subgingival things. Probing is the worst. You would think scaling is. No, the little blood vessels go, oh my God, and they close down. You get a higher rate of bacteremia with probing than scaling. Coronal polishing, you are flaring the cup subgingival, right? Intraligamentary injection, a PDL, when you go down in the pocket like a probe and into the PDL, that you're dragging through bacteria. Placement of orthodontic bands. These guys, not brackets. Okay, so orthodontic bands. Endo, because we're dealing inside the tissue with bacteria. Periodontal surgery, we're making a big old flap, things like that. No pre-med for supragingival things that have a low risk of bacteremia. We took this bracket, we glued it on your tooth, we're done. Not scary, right? How about injections, blocks, or infiltrations? You're just making that little pinpoint puncture, right? And you're just on the mucosa somewhere, so you're not causing a giant amount of bacteria to go into the tissue. You're not going through the PDL. And things the patient does every day. What's one of the highest things you get bacteremia from? Brushing and flossing your teeth, especially if you have inflammation. But we expect the patient to do that every day. So guess what? Pre-med, you're on your own. It's not going to happen. We're not pre-medding you every time. Also, if you poop, you get bacteremia. We're not pre-medding for that. Just FYI. Okay, so that list, that's on the test. Okay, so pre-med for that guy, no pre-med for that guy. American Heart Association, prosthetic cardiac valve, prosthetic material used for valve repair, previous endocarditis, always, always. Does it really work? We don't have great evidence, but we're going to do it anyway because they scared us. Congenital heart disease only in the following categories, right? Gosh, it didn't work entirely well. So not just a cardiac transplant, but that they have valvular disease, right? So that's definitely on the test. There's the handout for the patient. You need to know the conditions and the procedures requiring pre-med. So what heart conditions and what procedures. 2,000 milligrams of amoxicillin is how many grams?
2.
Thank you. That was lovely. Please don't write 2,000 grams. Thank you. Penicillin allergy, what are you going to do? Was clindamycin coming out of your mouth somewhere then? Good. How many milligrams?
600.
And then when? When are we going to do that?
30 minutes.
1 hour before.
1 hour before. And then also think about the vascular procedures. When are we doing the vascular procedure compared to when are we going to pre-med them? Okay? Okay. Joint replacement. Do we pre-med joints?
No.
Unless,
Like previous infection.
and is it 100% of those people?
No, I mean, if they have complications,
If they have a joint
Immunocompromised.
What are we going to do before we pre-med them?
Med consult?
Med consult for high-risk patients only. Do not pre-med them automatically. The bacteria that cause those infections are not oral flora. Right? So, we may, for somebody who's very immunosuppressed, decide, even though they're not generally oral flora, we're going to pre-med them anyway. But that will be based on a consult. So you're not going to say pre-med, you're going to say consult. Okay, and again, 2 grams is how many milligrams?
2,000.
So 60 minutes is what we want. Amoxicillin is the drug of choice for joints and for heart valve or heart issues. We're going to use clindamycin otherwise. You can do up to 2 hours after, but that's only an emergency. Like you just completed a quadruplenty and then your patient says, oh, by the way, I think I forgot to tell you that I have blah, blah, blah. And your boss walks in and is like, I swear they did not tell me. So that is not a, oh, well, we'll do it 2 hours later. That's the, oh my God, you just told me this? It's only an emergency. All right, anticoagulation therapy, we want to know their INR.
3.
So this is for patients on Coumadin or warfarin. It's not any of the other anticoagulants because they work by different mechanisms. Okay? So when I say, what is your patient having their INR tested for? It's Coumadin use, anticoagulant use. What's your treatable range? You said 2 to 3, right? We can go as high as 3.5. Diabetes, what do you want to know?
What type?
A1C, because that's how long ago?
3.
That's all the last 3 months, and blood glucose today. Okay, do you care which one? Can you just do one or the other?
No.
You need both, right? You need to know what is their healing capacity or their likely incidence of infection, and what are we doing today? Somebody who's under good control can be in dire straits today. Okay, so that's the long term and the short term. That's 3 months retrospective, and the lifespan of the red blood cell, and that's normally a 6. What's our treatable range? A1C.
4.5. Treatable? Less than 8.5.
It's the random number generation.
Oh, 8.5.
By the first, know that. Okay? So short term, what do we want them to be short term? At least what? So we're not worried, I mean, obviously if they're 300, that's a problem, right? But what's our minimum? number?
One.
We want to know fasting or non-fasting. We want to know fasting is 70 or higher. Because if they're high, it's like, okay, it's not great, but you'll be conscious. But if they're below 70, we're in trouble, right? Do you guys have the PowerPoint downloaded from? Okay. This is a really hard time of day to do this. Okay. And then controlled, we're going to be about 120 or 130 less than or equal to, and yeah. But the big thing is, can we treat them today? They need to be at least 70. Complications are what?
Low healing.
Hypoglycemia and hyper. Which one do we care about? Hypo. We don't want them to crash and burn on us, right? What are we going to do for the hypoglycemia? Feed them, right? So sugar source. We have a couple of patients who are really brittle diabetics. We have one in particular who had our little gal who's just had the stents recently. She can just go off a cliff like pretty quick. Fortunately, she usually knows she's going off the edge. All right, syncope. So hypoglycemia is syncope. Syncope probably is the number one thing that happens in most dental offices. One of our previous anesthesiologists said, for some reason our patients don't eat before they come here, so we have a lot of hypoglycemia, more than you would normally see. Syncope, pallor, has any... So other than your lovely classmates' examples of fainting. So picture your lovely classmates where they just went totally white. Pallor, that's going to be your thing. People who don't have blood in their brain don't follow directions very well. You have to be very directive with them, get them someplace safe so they don't fall down. So we want them supine position and oxygen. So we need to get oxygen to their brain.
Sorry. Barbara's asked for you to mark off if you participated in CID right here. So just check it off.
Oh, I forgot to bring a sign-up sheet. Careers in dentistry. Monday's thing.
Are we all there?
Okay. Anybody seen it? Have you seen someone hyperventilate?
Yes,
Okay. I've seen like once in my life, ever. But here's the thing. It used to be, oh, breathe into the paper bag. Now they're saying, breathe into your cupped hands. So the person's going to feel like they're going to faint. But remember how I said pallor? This person will not have pallor because they got plenty of oxygen. They have too much. It's changing the pH of their bloodstream. They're going to have lightheadedness, paresthesia, so numbness or coldness of around their mouth. It can be their hands and feet. They can have tetany. This is tetany where they get little spasms in their hands, sometimes their feet, which is pretty weird for people. I have had a student do that on me. But they're going to be panting and like, yeah, you're breathing. You have enough oxygen. No more oxygen. Let's have you breathe into your cupped hands. Have them in an upright position. Reassure them. And then slow them down. This is the Lamaze breathing. Okay, breathe with me. 1, 2, 3, 4. 1, 2, 3. You know, walk them through it. This patient, supine. This patient, if you put them supine, they'll be more freaked out. Okay? There's no Boy Scout thing. If they're red, elevate their head. If they're pale, elevate their tail. Okay? So, there's that. So that was your review of MedComp. Okay, dental emergencies.
Cool.
So, those will be on ExamSoft. Sorry, I don't have an example question. It is going to be fill in the blank or multiple choice that you'll have to be able to do that. Treatment planning exam. You're going to have, yes.
Yes, who raised your hand?
Oh, that was me. Will this test be about the length of like a regular test?
So it's going to, you have 40 minutes to get it done in the room, sign in, do the 2 tests, sign out.
2 tests. Oh, both of them.
So I figure, I'll tell you why. When we grade it, we're not going to fail you if you don't do well on the med comp test because the interview is what we're going to count. It's kind of a spot check, but please don't make me remediate with you. We'll remediate, but it won't be the, oh my God, you can't be a senior. Pathology, however, that's I had to go in by hand in Exemplify last year and pull out the path questions. I said, sorry, you have two Exemplify quizzes this year. I'm not grading 2 things by hand. Because I had to figure out which questions made the not pass part. So, sorry, you'll have 2 passwords. I want to say it's like 5 lesions on the path test, so it's not bad.
The med comp that we just went over, is that how in depth we should go, or should we go through?
That's it.
Okay. Oh, deal.
People still fail, so please just don't, okay? Thanks. It'll make my life a whole lot easier. We'll save a lot of time. Okay, so then you're going to have a standardized patient. So you're going to have an individual patient that you're going to be able to go in Axiom training, which is almost exactly like being on Axiom in clinic. And all those things that are in there when you've done your data collection and you enter it are in there. So you're going to look at the images. You have intraoral photos. You have a 20 film FMX. And you have full data. And you have a note about the exam appointment they came to. And then you just have the note the patient's going to return for treatment planning, and that's you. Okay? The patient has their health history information and vitals. You're going to take that into account in how you potentially adapt or modify your treatment to that patient's needs. They're going to have some social history. You know what social history is?
Like smoking.
Smoking, drinking, right? Xerostomia,
Recreational.
all the stuff they tell you. You need to write that down and take it into account. So again, arrive early, but you'll be here for all the things all on the one day. So if you don't show up, I have to tell you on that. So on this thing, you are going to have already dropped off your cell phones, your laptops, because you don't need them for this test. You cannot have any personal items in there. You will have papers to fill out. You're going to have a case presentation form that's just like on clinic, and then there's a little response form that I'm going to show you that will give you some reminders. Make sure you said all the things to me. So all of your stuff need to be in your lockers. Your cell phones are going to be on the phone jail. Your laptops will be in 1176. You're not allowed to go once you have started the test. So don't be very dehydrated, but maybe be slightly dehydrated. You're not going to talk to each other at all. You're going to raise your hand. We're going to spread you out in the Nobel lab. We will come answer questions. I will personally be in there. God willing, the creek don't rise. I will be there. Right? Don't make me do the cavity searches. I do not want to do that. There is until I have the phone jail because I figured out somebody was using a cell phone texting to the restroom. So I want to know what's in your brain, your wonderful brains. Okay, so you'll sign on into your individual patient in Axiom training. I'm going to give you the password, and that person will be assigned to you. You're going to go through the entire chart just like clinic. Then you're going to fill in your case presentation page. So you didn't collect the data, but it's all there. You're going to answer some questions. You're going to complete this response form I gave you. Don't forget consults and medicaments. Those are both really, really commonly forgotten items. And then when you are done, you're going to raise your hand. One of the faculty will come over and we're going to assign you out of your patient. And we're actually going to go in then and remove, before you leave the classroom, I need to take your permission to see the patient away so that nobody, shares that inappropriately with anyone. Lead others not into temptation. So remember that you're going to have, both photographs and the FMX. So look at both of them. And then remember that bleeding, no bleeding, some of them have N. I made the patients for you, so I did not put N on any of your patients. It's bleeding or it's not. But there might be separation or exudate. There might be bleeding and exudate. So that's what those guys are. Okay? And that's how, by the way, you chart them if you see exudate and bleeding. Hardly ever are separate. You can go into your summaries and exams and you can kind of toggle back and forth between exams if you want. This particular set of patients does not have just more than the one set of data, so you won't have to do a lot of comparing. This should be in your head.
That's hard. Like even memorizing patient categories, 1 is this, 2 is that, 3 is that. Yeah.
So like 1, 2, 3.
So here's the thing. The category is a way to say, how long will it take you to get this patient clean? Right? How many teeth? How dirty are they? That's patient category. So, what's 1?
Light, nothing.
Right? What's a 5? Right? 3 is medium. If you're within 1, I give it to you.
Are these going to be written in text form or a photo, or how are we going to determine that?
You're going to have films, and you're going to have intraoral photos, and you're going to have data.
Okay.
So you just want us to know the patient categories?
Mm-hmm. So you're going to look at that and go, how hard is it? It's not that hard to figure out, guys. You could do it. I have faith in you. Okay. So this is going to be the hard part right here. And you guys have the blood pressure in your head, yes? And the major diseases. So ASA classification for an insulin-dependent diabetic? 3. Right? You got this. So look at your blood pressure, look at your categories, periodiagnosis. Make your way around this little loop-de-loop on your decision tree. Think about it. You can do it. All right. So, case presentation. Sorry, this is the old case presentation because I had only so much time to change all the things over. So, case presentation on this guy. Let me get back to this. Whoops. So if you're trying to open this guy, when it's a PDF, you can just open it. And so this is an example of what you should be doing in this form. So if you didn't know what goes in all the slots, that's what goes in all the slots.
So when you click it says you can't get to it, can't do that.
Okay. So the other way to try to get into it is,
Didn't you,
if you right-click,
yeah, didn't you post
you
it?
can say open, but it also might be posted.
Yeah, I think you posted
The
it.
example.
Yeah.
That's why there's so
In your
40
announcement.
billion things in there, so you can see the example. So you should be able to get to it one way or another. If not, let me know and I will post it if it's not already in the PowerPoint. Okay, this is the treatment response form because I figured out not everybody puts everything in the patient case presentation in the same place. Dear God, this is so hard to grade by myself, times 40. So, I gave you this treatment response form. So it is also going to prompt you, for instance, to tell me modifications to treatment. Did you think maybe you need some modifications to treatment? And so this is going to say, what's your medical complications? What are your diagnostic procedures, consultations that you need for this patient? What's your diagnosis? What's your treatment plan? What are your clinical interventions and medicaments that would be helpful? What's your plan for post-treatment assessment? What are your referrals you want to do? What recall? And what modifications to treatment? And can you treat this patient today? So, if you wrote it on this response form, but you did not write it on your clinic, the case presentation form, you will still get credit. I give you another bite at the apple, okay? If you only wrote it on case presentation, you forgot to put it on here, it's a lot of highlighters, but if I can find a place where you told me the answer, you get credit, okay? So please write everything down. So there's a blank form here, and then this is a filled out one of how you do this. I think this one is a picture. Maybe not. Yep, document object, open. Okay, so that's this. So, on this guy, you're going to talk about, so this will be the top of your case presentation form, right? That little health history slot. This is the rest of the top of it. What do you need? Radiographs, consults. Are you worried about something? This is your ASA and your treatment and your diagnosis. And then this is what are you going to do about it? So if you are going to do a perio maintenance or a prophy or scaling in the presence of inflammation.
Behind your head, there's a spider in the wall.
Oh wait, it just went under the thing.
Oh, it went
It went inside.
Inside.
Come back home.
Behind that little wooden
Like
Oh.
palette.
thing.
Palette.
Yeah, about that big.
She was a sneak.
You're going to tell me if you want to do quads, and you're going to tell me which quads. So if you want to do upper right, you're going to say upper right for more root planing. Oh, I want to do lower left, posterior sextant of root planing. Put it over there. Okay? You cannot mix these up. You could do 4 quads. You could do, we don't usually do 6 sextants because that's 4 quads, right? Don't do that. But if you think, okay, I just need this sextant and that sextant, and then we're good, that's fine. But then don't tell me you're also doing a perio maintenance, because those do not go together.
I'm sorry.
Does that make sense? If you're doing something that is a full mouth, it does not go with quads or sextants. Either you're doing quads or sextants, or you're doing a full mouth procedure. Do not put them together.
So perio maintenance is full mouth.
Perio maintenance is full mouth,
So
it
this is
goes
like
over there, and
SRP?
that's it.
Okay.
So we would just mark right where it says full mouth,
Right
just
where it
ignore the
says.
rest. Okay.
Okay? Don't double dip. We can't bill them twice.
So the
There are rules
quadrants
about that.
procedures would be like SRP and
And it's 4 or more teeth,
okay. So
So-
it would just be the only option is SRP if we're doing the quadrant
right?
thing.
And I did this little visually so you would I could try to rein you into one plan.
Yeah.
What is a prophy?
Cleaning. Preventative.
Buckle-like.
Full mouth.
Is it coronal polish?
Yes.
Yeah.
And
And scale.
Okay, so don't tell me that you're going to do a prophy, meaning you're going to coronal polish this patient at some point, because that is not a prophy. A prophy is a whole procedure unto itself. Does that make sense?
So we don't trophy on.
No, you coronal polish somebody,
Oh, I get what you're saying.
right? It's 2 different things. People will say, oh, we're going to prophy this patient. You're going to coronal polish that patient.
But that goes under the category.
So that could
of
happen
trophy.
at a perio reeval, it could happen at
Yeah,
a scaling,
yeah.
right? That's a procedure that's part of
Yeah.
the overall treatment plan, which is prophy or perio maintenance or reevaluation, right? Okay, so then educational interventions and medicaments. So tobacco cessation, nutrition counseling, the in-office things, the home things, Prevident, MI-Paste, Biotine, any of that stuff. Okay, and then post-treatment. What do you need post-treatment assessment for?
Make sure what you did work.
To make sure what you did worked. So what procedures? SRP. Maybe scaling in the presence of severe generalized, moderate to severe generalized inflammation. Okay. So reevaluation 4 to 6 weeks, absolutely, positively on every root planning patient. Write that down right now.
Whoa.
Can you say
One more time.
Perio reeval, 4 to 6 weeks, every root planning patient, every time. So here's what I forgot to say.
4 to 6 week recall.
Can y'all open this for me, please?
Oh, yeah,
The genetic study guide.
yeah. Takes long.
Okay. So, 4 to 6 weeks, every single patient that you do root planning on, reeval, full data, did it work? Is the patient responding? Recall. That is different from reeval. There's reeval and there's recall. The reeval is 4 to 6 weeks, how's the healing? It's a, how you doing? Recall is what? When I'm going to see you next for the next whole procedure. Okay? So if you're an adult prophy, likely the next recall will be what? 6 months. 6 months what?
Recall.
I think it'll probably be a prophy, right? 6 month prophy. If they just had root planning with you, it's going to be
4 to 6
4 to
weeks.
6 weeks.
4 to 6 weeks, re-eval, but now we're saying recall. 3 months, and it's probably going to be perio maintenance.
So it's like a ladder.
Okay, so perio maintenance is what happens after root planing, so long as they're under control. Okay, prophy, every 6 months. As you teach it, right? So I'm getting the tap shoes out next. Root planing. Ah! Reval. Oh, okay. All right. Perio maintenance every 3 months. Right? Yes? Good. Okay. So, scaling in the presence of generalized moderate to severe inflammation, I'm thinking reeval in 3 months. And then show me you can do well, and then we'll talk 6 months prophy. Okay? All right. So there's that. Here are the boo-boos. You messed up on your assessment of their medical history. You gave them the wrong AAP classification. You picked the wrong treatment plan, or you can't tell me reliably about radiographic bone levels or calculus. Or you forgot, perio consult. Or you forgot the reevaluation, or you forgot a periodic oral exam, dental exam. Remember, you can't fix everything. You need the dentist with you on this, especially if you have new x-rays. Right on the side of your paper, write down new x-rays. Periodic exam. Gingival evaluation issues, you're like, oh, everything's healthy, and I'm going, really? Because this scares me? Or vice versa, that's a problem. Medicaments that you might need. So there is the rubric. These are the critical errors on that side. Okay? So, no critical errors in here, or also not a whole bunch of little things that I'm like, you just don't quite have this yet. You need more practice at it. Okay, this is on the paper I gave you. So this is actually correct. The thing that was wrong on this guy was that at one point we talk about localized generalized as being 30%, but when we're talking bleeding, generalized is 10% of the teeth. So on a patient with 28 teeth, if 3 teeth are bleeding, they now have gingivitis. They're not healthy anymore. So I fixed that. Sorry about the incorrect numbers. We always look at radiographs, right? Why do we look at radiographs? How worried are you about this tooth? They have 2 millimeters of recession, maybe 3, and they have a 2 millimeter pocket. How worried are you? Well, that's good. You're more concerned. Yay. How worried are you now?
Oh man, where'd it go?
Slightly terrified, right? This is splinted because otherwise this tooth would be gone because it will not be able to stand up to this trauma. Okay? So, look at your x-rays. Think about percentage of the root as far as bone loss. What is 15% about what part of the tooth? Root. About a sixth. Somewhere around a sixth. If it's more than a sixth, then we're already at moderate. Okay, so remember, normal anatomy, nice healthy crest of bone. There's a space between the edge of the enamel and the crest of bone that's called between the CJ and the crest of bone. That's the space for the periodontal. What part of the periodontal ligament? Junctional epithelium lives in there, right? Has to have a little room. The bone doesn't touch the enamel. There's a little room for the junctional epithelium. That's where it's attached. And we call that biologic width. Does that ring a bell? Good. I'm starting to get a little worried. Okay. So, well-mineralized crest, we're happy, right? Okay. So, we're going to think about what's the 15% bone loss slight, 15 to 33%. So, 1/3 moderate, more than 1/3 severe. So, if it's in that middle part of that root, we're in trouble. So, remember how this used to be 1, 2, 3, 4? Did we have this picture before 1, 2, 3, 4? Anyway, it's not 1, 2, 3, 4 anymore. Now we're health or maybe gingivitis because we can't see the soft tissue. Stage 1 perio, we have some early CAL, clinical attachment loss. We have, oh, yikes, 2 or 3, significant, moderate to maybe severe attachment loss. And then this is just, whoa, that's that severe complex. These teeth, if they breathe hard, are going to go like this, yes?
Yeah. What about the healthy but reduced periodontium?
So this person, if they were in good control, could be healthy but reduced periodontium. So could that person, so could that person. Okay, not that person, never mind. That's too scary. Okay? All right, so ADPIDE, does that also ring a bell? I hope. Okay, so we're going to assess. So we're taking data, we're taking films, we're going over the health history, we're doing our EOIO, all that stuff. Vital signs, to get all the information we need. Then we're going to do a diagnosis and a plan for our hygiene procedures. So scaling, root plating, maintenance, preventive treatment. We're going to implement our hygiene treatment. Meaning we're going to actually perform the therapy. And then we're going to do that post-treatment evaluation. Did it work? So, uncommon, interim evaluation, uncommon, 1 to 2 weeks. That's if somebody has really, really scary inflammation that I think I need to know if they're healing in this first week or 2 because they might get worse. So somebody who had a nug, that's my interim evaluation person. Somebody who had an abscess, there's my interim evaluation. For everybody else who's more the garden variety, somewhat scary, 4 to 6 weeks, reevaluation after every root planing. Did you write it down again? Write it down again. At that reevaluation, full data and a perio consult. So then we're going to decide if we need referral. Did we deal with their problem, or do they need more help that we cannot provide them? And the first thing that I always think of with referral is if you didn't already send them for their dental restorative exam, what are you waiting for? Refer them to the dentist. Recall 3 months for most perio patients, especially that first one. I really want to see their track record. Are they going to actually maintain for that first 3 months? You are not getting further away from me than 3 months, if I can help it at all. Okay, so our assessments: health history, vitals, EOIO, radiographs, full data, CAL and bleeding, right? Now with this new system, CAL and bleeding are the things that are going to tell you what your diagnosis and therefore your treatment plan are.
Is it vitals before health history, or is it not gonna matter on this?
It's just all in the same
Okay.
bucket of information. Okay, and then think about Carrie's risk, because that might change medicaments and adjunctive treatment, right? What medicaments come to mind immediately when you think high Carrie's risk?
Am I?
And my pace, fluoride, right? Okay, Cal. Do we get Cal yet? Yeah, okay. I have a couple of sheepish. I'm not 100% sure people, it's okay. Okay, this one's easy because recession, so you can see the CEJ. You just drop the probe down there and go, ah, that's how deep it is from the CEJ to the base of the pocket. Okay? If the gingival margin's at the CEJ, then what do you know? The probing pocket depth is the Cal, right? Because it's CEJ to the base of the pocket. Everybody with me? Good, okay. This is the hard part, is knowing, where is the CEJ? So I know I've worked with a few people already, if you haven't figured it out, to figure out where the CEJ is, lean your probe in too far, bump over the CEJ, figure out how many millimeters that is into the pocket, drop down into the pocket, figure out how many millimeters total it is, and then take off the part that is against enamel. The tissue that's against the enamel, we don't care. We care what's exposed root surface from the CEJ to the base of the pocket. Okay. So, 6 millimeter pocket, but we still have hypertrophy, or maybe we have kind of in what used to be a normal pocket. It doesn't have to be extra swollen. So 3 millimeters of this is actually overlying enamel. We don't care. That would be normal if they didn't have a lot of inflammation, right? So this 3 millimeters is that actual attachment loss. This is 6. This is 9. So same probing pocket depth, 3 different numbers for Cal. Making sense? Good. All right, if you have questions, find me later. So that part we're not going to say is attachment loss. That is not attachment. This is 6 millimeters of attachment loss. That's 9 millimeters of attachment loss. Okay, consultations. I don't know enough about this patient. Please come make your expert decision for me. Consultation. So, could be oral path, oral surgery, grad perio, grad endo, any of the departments here, but also our physician or our general dentist. So some days we need to call Dr. Jewell over to evaluate something, and we're happy with, we all feel comfortable with that. Sometimes we do need that specialist, and then sometimes we need to send them for med consult because we're just not sure that we're going to be able to treat them safely unless they either have some intervention or we have more information to know that we are safe, right? So this is the tell me more that I don't know so I know I'm safe with this patient. And then all of these things that you guys figure out, those are your results, right? This is what you've been doing every day since the beginning of clinic, because you're awesome. So, remember though, need for referral, grad perio if they're root planing, and we haven't fixed everything, dental student for periodic exam or any restorative treatment. Those are the things you guys forget to write down.
For like a dental exam,
Mm-hmm.
They have to have one every year. Did you already mention that? Or is it one
So
every
normally
2
they
years?
do want to have one every year.
Every year.
What's
Oh,
the, for sure, we're having a dental exam, ASAP. Every time we do new what?
I'm not X-ray.
X-rays. If you just took an FMX or new bite wings and you don't send them for a dentist to evaluate, right? Everybody gets to look at the X-rays and assess.
FMX is every 4 years? 3 to 5.
3 to 5.
3 to 5 in general, based on patient need. Does that mean that Ms. Lee and I have not taken a patient who that we had an FMX last year and their periodontal condition went, oh dear God, and we took new films? We've done that. So it's based on patient need, but the overall average is 3 to 5 years. And bite wings, I mean, I've worked in offices where they did them every 6 months. I didn't work there long.
What is
We
the-
did have patients that needed every 6 months in one of my corona offices, because no fluoride, right? So we had kids that were living on atomic warheads. I can see new white spot lesions 6 months later. Great, let's take more films. Okay, but you may have the patient that every couple of years you take bite wings.
So it's every couple of years?
Depends on the
Depending on
patient, right? So a lot of you guys would be, see you next year, right? Okay. So preventive, pro-fee, scaling the presence of right? So this is kind of our hybrid code of, we don't have cal, but we will soon if we don't move it. So I consider it preventive, but also we are treating inflammation, right? So it's kind of in the middle. But these are full mouth codes. Maintenance, they've had disease. We're happy if they're healthy, but reduced periodontium. And so we're, okay, you're under control. We're doing this full mouth procedure that's maintaining you. Active periodontal treatment, quadrants or sextants. And you're not going to combine a full mouth anything with a sextant or quadrant anything. No double dipping on their insurance. There are rules about when you can say, oh, you're going to have a root plane in one area. Nah, it's too confusing. We have too many patients with different insurance. We do one or the other. Pick one. Okay? Reassessment, so 4 to 6 weeks. It's in red, 4 to 6 weeks. Reevaluation. Don't forget it. Thank you. And you're going to decide maintenance, additional active treatment, referral to a specialist. Did what you do, handle it. Do they need some more help, like some periodontal surgery? Or do you need to re-root plane something? So you might reevaluate the pro-fee or the perio maintenance patient, or for sure that scaling the presence of generalized inflammation person. But think about what that patient needs. Am I going to give you a scary hard patient to decide? You're juniors, right? That's the don't panic. Take it seriously, but don't panic. Okay, so healthy patient 6 months, perio disease, current or past, 3 months. I want to hang on to them. And it takes about 12 weeks for the perio pockets to recolonize from the supragingival bacteria, so get in there again. And our big thing is cal is not getting worse, and they have no bleeding, right? Those are the two big criteria. Also, pockets under control. Okay, that should be pretty familiar now. Does this all make sense? You can go around the little loop-de-loops of that. And you're asleep. Lost you. Hello. Sorry, we still got to get through this. So does this make sense?
Yes.
Right, because Ms. Lee torturously and tediously made the little red arrows for you, and we went around with the little loop-de-loops, yes? Okay, we'll make it a board game. Okay, things that people fail on. They tell me that the patient had an exam when there's no exam written in the chart. If there is no dental exam written in the chart by somebody who is a dentist, then there is no dental exam done. Do not make stuff up. Okay? Look in the chart, read the chart. Do not read into the chart, just read the chart. Remember, you need to consult if you are getting a diagnosis of periodontal disease. Now, that's not going to be that way in private practice because general dentists can go, yeah, go root plane, make more money. Good. You need treatment plan approval for that root planing here, though. And you need a and you need a consult from the periodontist for a diagnosis and referral for sure. So, tell me at some point that somebody dentist is going to look at your patient, and that if you need root planing, you will get a consult from a periodontist. That will be a happy camper. Remember, the reeval is the thing that is common. The interim evaluation is uncommon. So unless you have a particularly terrifying spot, just think about the reeval if you have done active periodontal therapy. Okay, treatment planning.
Yes. So for the the re-eval versus the
Recall.
re-eval versus the
Interim?
yes.
Okay. Interim is how soon?
Oh,
1 to 2 weeks. What kind of
Okay.
patient?
Like a really bad.
Ah!
person with nug.
Okay.
They have a nug. I'm afraid their teeth will fall out because of the abscess. We think we got it cleaned out, but we're going to check it. Stuff like that.
The treatment plan approval for root planing, like where would we
We
write
need it.
that?
We need a perioconsult for that, is what I'm
So
saying.
as long as we put perioconsult, that covers that.
Yep.
For the interim eval, do we probe for that evaluation, or do we not?
Okay, interim evaluation, you don't probe. Why?
You don't want to damage any.
What stage of wound healing? They talked about wound healing in perio, yes? Right, so you'll destroy any new or, reattachment. You don't get new attachment without specific surgery. But reattachment, you will disturb that. So you do not want to go poking in there for 4 to 6 weeks. Okay. These are the things right there that people fail on. Okay. Okay. Clinical exam. Every day on clinic, what do?
Clean your cubicle.
You set up your cubicle. What do you do next?
Log on
Health
to
history.
You do health history. That's going to be on this patient. What else do you do? Vitals. EOIO.
Instructor check. Instructor check.
There will be an instructor check. How do you do it? Right? And you're going to do 2 injections. That's it. Clean up. Done. Okay, you've done this every day on clinic. You can do it. Yes.
If we pass the injections, can we get credit?
No, so no double dipping.
Oh, so, Selena?
Not a comp. It's an OSCE.
It's just gonna be 2 random injections?
Yes, we're going to talk about that.
Who do we do on? Is it
It's your partner again. I know.
Our original planner or like another mix-up?
I pulled y'all out of the mug again today.
Oh.
Everybody's out of the mug again.
What does that mean?
Probably in a few days.
You pulled us out of the what?
The sorting mug. I don't have a sorting hat. I have a sorting mug.
Oh.
Gryffindor.
I see.
It's a sorting mug. I drink very strong coffee, so Mrs. Witt, did you get to meet? You got to meet Mrs. Witt. So she bought me a mug. Dear God, the thing's a soup bowl. Like, I will go into orbit if I drink this mug. So it's the sorting mug.
I'm like, sorry, now what?
And then she had the stroke. Okay. Okay, so that's what you're doing. Operatory setup, vitals, EOIO, local anesthesia administration. And the local anesthesia administration, exactly what we did on the competency exam. Okay? Except, what did we practice in pain control block this quarter? What was different? Non-dominant side. Okay? So what do you know, Thursday, August, you're going to be, you'll sleep well that night. We'll all sleep well. We'll just fall face forward into the carpet. Again, don't go get lost somewhere. Stay here. Eat well. You're going to wait. I think the best thing is the main lobby area because we don't have a hallway anymore. Right? So wait in the main lobby. We'll call you in a group. Stethoscope, blood pressure cuff, cassette with your mirror, syringe, cotton pliers. I will have pencils and everything else. This is the schedule. Y'all are going to set up. You're going to take vital signs, EOIO, anesthesia. You're going to change. Set up, vital signs, EOIO, anesthesia. And then both of you will document your anesthesia at the same time, just like last time. And there will be now a little response form on the clinic computer desktop that you're going to fill in. What were the vitals? And 3 absolute contraindications to use of vasoconstrictor. Okay, hypertension, uncontrolled. Hyperthyroid, uncontrolled. It has to say uncontrolled. Drug use, like ever?
Control.
Control cocaine drug.
Right. So when? Drug use when?
Last 24 hours.
Last 24 hours. Especially what drug? Cocaine and
Speed.
meth. Cocaine, methamphetamine. Okay. Yes, sulfite allergy. Sure. Don't tell me 6 months ago within the last 6 months they had a stroke, because that means you can't treat them at all. Tell me something really specific to vasoconstrictor. Okay? What's another one?
Diabetes.
Uncontrolled diabetes. Like, if you say uncontrolled, think of a word that goes with uncontrolled. Write that down. But think about it, too, because you want to know all these things. How about glaucoma?
Uncontrolled.
Even controlled glaucoma, you don't want a vasoconstrictor. Okay? So think about that. Go back and look at your list. Okay, so that's the way this goes. Dear God will be here forever, but you will have your, hour and 10 minutes in the sun, and then you're out. Okay? So, we're going to get you about a few minutes ahead of time to go over your health history briefly with your instructor. I'm going to rely on you as patients to say, hey, I have this issue, if you come up with something between now and then. Because the vitals you're taking as part of your exam. Don't take vitals ahead. That's part of the exam. So, I have instructions posted so that you can refer to them. It's taped up next to your computer, so if you lose your mind because you're so tired and exhausted and stressed out, you can refer to them. So make sure, like I say, that your partner knows what's up. This is the rubric for operatory prep. So we went through this when we did operatory prep the first time in preclinical about 400 years ago. Okay, 8 months, 7. Please wipe all the surfaces inside the hangers and everything you touch. This is not the day to forget sticky wrap anyplace. And I have walked into clinic and had that. Yeah. If you're not wiping in there, that's why. Because you don't always see the blood inside the hanger for the suction. Right? So always, always. Vital signs, things people fail on. Let me put the cuff down below their elbow and shove the stethoscope under it and pump it up like, we have had a little, one of our little old people with a nice round bruise because somebody smushed the stethoscope onto their arm with the blood pressure cuff. Please don't do that, and ow. So make sure your cuff is high enough. The bladder is over there. You do have a little artery arrow. Use the artery arrow to point to the artery, which is that side, not that side. And that you are doing your estimated blood pressure. Right, so vitals, first thing you're going to check is
Estimated blood pressure.
on the radial pulse, right? Put the cuff on, blow it up, feel for the radial pulse to disappear. Don't listen, just feel. Deflate during the time it's deflated.
Oh, we tried.
Not respirations yet. No thumb, index finger or fingers. This has its own pulse, right? So use your fingers to take their pulse. Are we going to tell them when we're done with the pulse for 30 seconds that we're taking respiration? Your partner will know. Try to fake it, but you don't know. No coaching. Check respirations. Quick, write those 2 down. Come back. Now what?
Blood pressure.
Do it again.
Final blood pressure. Now we're listening, right?
Can we make sure there's a clock with the seconds? Because one of
You
them
can
is
wear a
like-
watch or you can look at a wall.
If you click in the clock of your computer, it will pop up.
Okay? All right, so that's a no. Patient position, that's the other thing. Okay? So we don't take blood pressure standing up in dentistry. Yeah, they do take blood pressure standing up. We're not doing that. And 30 seconds each, and you're going to document them on that response form. EOIO, you have to tell me all these structures. See that giant list? all those structures. When you're saying the words, you should be on those structures. I'm on the temporalis. Oh. Is this the parotid? No. Right, know where they are. Look, feel, listen, the whole bit. Went through. Can you guys still get into preclinical to see the videos?
Yeah.
I'll try to remember to email me and ask me to post them.
I
Okay?
think they're on my link as well, if I'm not mistaken,
Okay.
in seminar.
So we'll look for those. Okay. So you got to be telling me the structure, or your faculty, and you got to be on the right structure when you're saying those words. So know what they are. So we'll work on getting that. Local anesthesia, what do you know? Here's what I changed. Correct sharps and pharmaceutical waste. We're just grading you on that on once. You're welcome, Ms. Lee. And also documentation, just grading you once. It doesn't matter. People don't fail on points or anything. No, this is either you know it or you don't, right? So you can use the computer calculator to calculate your dosages. You will not have your phone, but you can use the computer because Reb Anesthesia Exam lets you.
The failure for documentation on anesthesia is knowing the milligrams for the type of anesthetic that you're using. So memorize those numbers or figure out how to calculate it.
Right, and you have tables for that. Okay, and then this is the response form. So you're going to say blood pressure, pulse, respiration, and then this is going to tell you how to do your note, and then it has a space that this thing cut off that says 3 absolute contraindications to use the vasoconstrictor: uncontrolled, uncontrolled, uncontrolled. You're going to print it to the printer. We'll figure that out before the 1st. And you will run over to Jeanette and get your printed copy. You'll bring it back, you'll turn it in, and then you will be dismissed formally. Usually we're going to do big groups, but like there are no secrets. It's can you do an EOIO, right? Same deal. What do you know? Vitals we will have already done. First one, IA, PSA, you're going to roll for that. So we have the same people who can't really receive IA, depends on how tolerant their gag reflex or whatever is happening is. The others will be naso, greater, infiltration, just like the comp exam that we already practiced, just on the other side. Okay? Non-dominant. Right,
So
sorry,
they're all
you.
going to be non-dominant?
Everything's non-dominant.
Okay.
It is not nice to do one here and one there to people. No, I will not do that to you. So you're going to roll for these just like we did last time. When we get to the senior one, I have a 20-sided or a 10-sided die for that because yes, Dungeons and Dragons, that's how I met my husband.
Sorry, no, go back, go forward now. It says right or left, but it is going to be non-dominant.
It's non-dominant. Okay, when you're a senior, you're going to roll for the side as well. Because one day somebody said to me, I've never done one of these on the left side, and I went, okay, I'm done with that.
Oh, gosh.
That can't happen again. Okay, so remember we're going to palpate place your topical at the same time, and then you're going to assemble. Don't burn up your time, but you still have half an hour. You can do it. So 3%, how many milligrams in one cartridge of 3%? 54. Right? Almost 60, because it's almost 2 milliliters, so 3 times, yeah. So, Ms. Hayton's current MedComp checklist of what not to do. Look at that. I give up. Look at that. So, I've been really bad at having people wipe and dry tissue. Have you guys been teaching that, Ms. Lee?
What?
Wipe and dry the tissue?
Absolutely.
Okay.
It absorbs the topical better.
It's not going to be a critical thing, but it does help if you wipe it. Please don't fire hose the inside of their lip doing your anesthetic pathway. You should be in control at this point to be able to do a reasonable anesthetic pathway and have enough anesthetic to do the injection. I will not make you do full amounts, but you have to tell me full amounts. Tell your instructor. Aspiration appropriately, deposition rate appropriately, all those things. And then scoop technique with that cardboard shield. Do not touch that with your hand, please. Be safe. Don't get your other hand in on the act.
But you
Until
can touch the cap, but not the cardboard.
then, not the cardboard. Maybe I should get rulers for you. Just whap them once.
Wait, is that?
Negative free.
Okay. It's an old joke now, right? If you don't have the patient in the right position, what are we doing, right? So I don't want to see any PSAs with people sitting up at 45 degrees. I want to see supine for that. I want to see supine for the non-dominant IA, because that was pretty awesome, right? And you got to have a fulcrum. So if you haven't figured out a fulcrum yet, let us know. We'll work with you. You're going to tell us. You're going to walk us through it. You're going to tell us penetration, excited deposition. I'm aspirating. My aspiration is negative. I'm the kid in the backseat of the car. Are we there yet? Are we there yet? And you're going to tell us regions of anesthesia. You're going to give us appropriate notes. You're going to be graded clinically acceptable or not. We used to do points. It was ridiculous because I had people that gave me quarter points. I don't care about a quarter point. Could they do the injection? That's what I care about. Please just do the injection. You can do it. All that review stuff is, oops, it's not in seminar, it's in clinic. Because one of the problems with Canvas is I couldn't get into seminar with Ms. Lee. So that's all in clinic. So no critical errors, or again, not a whole bunch of minor stuff that just adds up and adds up that makes me think you just need more practice. This stuff, that's going to be failures, asepsis issues. If you touch the needle, just handle it correctly. Don't freak out if you have a positive aspiration. It happens to the best of us. Just handle it correctly. And then aspirate. Okay. Summative exam versus formative. Again, this is the summative. Have you acquired the skills, knowledge, attitude to be able to get this done effectively and safely and professionally? We do expect increasing competency each quarter. So last quarter we were like, could you evaluate your position? Wait a minute. This time it'll be, maybe, if we're really seeing you struggle, please evaluate your positioning. We won't necessarily say patient position or your operator position, because we expect you just leveled up. Okay? We're not going to talk about grading. It is what it is. I have lovely, well-calibrated faculty. They're going to tell me. I will post it. We don't have time to talk about it. We will give you lots of documentation so that you know what's up. I will work on getting, depends on the level of exhaustion by the end of this day. However, I will work on getting the clinical portion posted as soon as possible. I have tried to do it that night most of the time. Occasionally I've had to do the next day. Okay? So, I will do my best on that day. Treatment planning, how much is that reading? You're giving me 2 full pages of notes, right? Times 40 people, 1 woman. Hang on. I'll get it to you as quickly as I can. Okay? Okay, clinical exam questions? Right? So this is why we always introduce those rubrics as you're doing your first practice. Download the rubrics, check yourself in clinic. Anesthesia, we did the pain control block. Remember I said it doesn't have to be me that you practice with. It's on you at this point to get with somebody. Well, just like with the competency exam, you can always go into clinic. When we're in clinic, if you don't have a patient or if you're a floater, you don't need to chart for somebody right now, grab a friend, toss them in the chair, no poking, but you can do grasp fulcrums. Cotton rolls work really good in the syringe with the cap on the needle, so you can do all your angles and such. You can get out the mirror and check out your points of penetration and everything. And absolutely, if we have some time, like when all of the people are doing data collection and we're sitting around twiddling our thumbs, and you're the floater, and you're waiting for them to be done with, vitals and health history and their EOIO, So you're kind of picking your nose. That's a good time to get an injection or two done for practice, okay? So look for people who are available. The nice thing about being the only class here is that, for instance, I had 2 people this morning and neither of them had a patient, so I went and did OSCE stuff. But we do have more faculty available per student in the summer. Please take advantage of that because you got 2 weeks. Okay, let me quickly, how are we doing? Great.
4:30.
Okay, so let's see. What else is in here that will be helpful? So Brian, if you would be able to make this tape recording with the stupid jokes available to your classmates who are not here because HIV?
Oh.
What's happening today? HIV?
Yeah.
That'd be awesome, thank you.
Yeah.
It might be confusing, so that will be a good study thing. Oh, and here she meant. Okay, so these are your answers right here to the quizzes, and the procedures, the treatment plan that people forget. So fill in that. This is this PowerPoint. This one is so remember how I said, oops, wrong number? So I fixed some of this PowerPoint. So download that again because that was the one that I did in 323 when we did some practice cases. And this will be the most accurate because it has the, oh, I fixed it 10% thing in there. Okay? So that's the treatment planning and case presentation 2019. This is your case presentation page. This is the example. So that's the one that you couldn't necessarily make it pop out of the PowerPoint. So sorry, this one is the 2018 because I ran out of time. So this part, the gingivitis and periodontitis, is not correct. But the rest of this will tell you what we expect in these little areas. What's your treatment plan? Is it a prophy? Is it whatever? So sorry, you might need your loops to read some of it because it's automatic. But that will give you an idea of what needs to be in there. Okay. What else is in this Canvas module? This is the response form, and that's the example. So again, it's last year's or 2 years ago. Oh, I'm sorry. This doesn't matter because it stayed the same since 2017. Did not need to be edited. I would go through that a few times, take some cases. And in fact, go ahead and open the one that's not the example as well, and we're going to talk about a case or two here. This is the overall schedule for the crazy day. This is the clinical OSCE schedule I showed you. These are the rubrics that I showed you. Okay, remember this case 2, 3, 2, 5, and 8 that we looked at already? Sure it is, Lennon. Let's see. Let me get to these guys. Okay, so I went in my announcement, I said, hey, please take a brief look at these because we did go over them. Okay, does this ring a bell at all? Okay, so what did we say on this patient? Do they have cal? Yes. Okay. Are you concerned about that? A little? What do you see up here? Calculus, right? What's the tissue look like? Oh, a little rolled, a little boggy, right? It's not like, oh dear God, but it's not good because we're losing some bone. Generalized, what kind of bone loss?
Or horizontal.
Horizontal, right?
Okay.
Okay. So, what do you think? If we have that much calculus and we have this much bleeding.
100%. Oh. Gingivitis.
Do we have cal?
Yes. Oh, yeah.
Okay. Diagnosis,
Oh.
stage.
I'll take 2.
Cal is 3 and 4.
Stage 2.
Stage 2. Okay. So automatically stage 2, periodontitis means we're out of control. Because the bleeding, the current inflammation, is what makes them stage 2. Instead of if they had this much cal, no deposits, no bleeding, immaculate plaque control, 3 millimeter pockets, they would be what diagnosis? Healthy but reduced periodontium. Okay, the fact they're stage 2 means, things are not under control. We have to treat. What's the treatment?
So if there was no cal, 3/4s, they would just be healthy.
That's our paper.
Would be
SRP. What did I say about the word prophy?
Oh,
It's not,
coronal
yeah.
polishing.
That boat sailed a long time ago, right? They're not ever going to be a prophy.
So they'll be
So the perio maintenance. Perio, yeah.
So root planing because bleeding, currently breaking down. Bleeding, 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 bleeding. Did I make it clear enough? Bleeding. There's bleeding. There's some bleeding.
Wink, wink.
There's bleeding. Okay. When I ask people to find me a case, I say slap your mama case. Okay? It's not going to be obscure. Okay? Bleeding, calculus equals root planing, right? Because we got to get this under control. So that is root planing. Should the word prophy come into this at all?
No.
Right? Cal, done. There is no more prophy for you.
That's it.
Okay? You are done. When we are finished with the root planing, what do we do next?
Re-eval.
Reevaluation. How long?
3 to 4 weeks. 4 to 6 weeks.
4 to 6 weeks. What do we do at that appointment?
Check for
Full data, check for healing. Okay.
Sure.
Oh, you were awesome. You got every microbe out of there. You were great at teaching them. They could come do oral hygiene instruction in your office for you with the other patients. Right? It's this. So, I'm not a soccer fan, but that's right. So, then what are they?
3-month recall.
Yes, 3-month recall. Perio maintenance. Okay. 3 years down the road, something terrible happens in their life. You know, they have a sick parent that is they're taking care of. They have some giant family thing. They're not eating well. They floss. Come on, I'm good to get out of bed in the morning and put clothes on. They start bleeding again. The pockets creep up to 3, 4, 5. Now what? We're back to perio. Right? We have active perio. We need to do active periodontal treatment. Making sense?
So if we, after doing all this with perio, is that going to need to get a consult from the perio?
Ding, 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 ding. Yes.
That's before root planing though, right?
Yes.
And is root planing and SRP the same thing?
Yes. Scaling and root planing.
Okay.
But we also get a consult at the reevaluation.
So we usually get a consult at the reevaluation too.
And then, does Dr. Jewel have to see every patient every time?
No.
Okay, so when does she need to be seeing our patients?
So we need to have a dental exam. So she's going to come and say, yeah, go get a dental exam. And refer them to a dental student.
Oh, so like
In
if
private
we
practice,
further.
your dentist boss would come and do the exam. Okay, but here we're going to send them to a dental
So they have
student.
like an abscess or radio.
Say dentist exam somewhere, please. Okay, please, if they have new stuff that needs an exam.
So when you do SRP or root planing, how much subgingival do you want us to go? Because that's
How
where.
deep is that pocket?
So we can go a little bit deeper than that.
Do you want to go deeper than that? So, when I anesthetize a patient, you know, I do the all exam and we take the FMX and we move on and we bring the patient back next week after we've gotten them to sign the consent, we're all set. And I anesthetize that quad and the first thing I do while they're getting numb is probe. everything. Where exactly is the 4? Where's the 3? Where's the 2? I would like the 2 to still be a 2. I would like the 4 to still be, to be clean to the base of the pocket, but not be a 6. Right? When we're done. Okay. So this person had the soma and the Norco and herniated disc and all this stuff. And so we were worried about dry mouth because of pain meds. So we talked about biotin, some of that stuff. Right, so back pain, Norco. We took FMX last week. Their last bite wings for 15 years ago. Here's the other thing. If I took full mouth x-rays last week, do I need bite wings?
No.
Did we just now take them?
Yes.
Right? Thank you. One or the other. FMX includes bite wings. Okay, so FMX, although these days with Alara, then we're working on, whatever we did was adequate to diagnose. So no bite wings. We're done. We're not taking more films. Start with all of that. Medical stuff, do your radiographic evaluation. Your radiographic evaluation should directly tell you, perio or not, right? Please remember this part of do I need to give them a medicament? Do I need to think about some urgent need they have? Do they have pathology? Do they have stuff I need to send them for a consult? You will have pictures to do your very best. They're not perfect. Every single tiny area of the mouth is not on the intraoral photos, but you can tell if they're inflamed, right? Or healthy, knife-edged, bulbous, all those things. Assessing the deposits, and then you should be able to sum this stuff up. So take a look at how I have summed these up. Notes, anything that you need to do urgently, or a modification to treatment, or just remember, please don't stand the poor patient with the neck injury on their head. Any of those kinds of things. And then this, is the old, that's the old one. But mark the new diagnosis and treatment plan. And then make sure you've got all your clinic procedures, and then sequence and priority. What's the first thing you're going to do at that first appointment? And then what might be the next thing. So with this patient, oral hygiene instruction, tobacco cessation, nutrition, root play in the upper right quad with anesthesia, periodic oral exam with the dentist.
With this list, you said that this portion is incorrect.
Sorry, this part is incorrect. Oh, no, sorry. See, I was up till 3 doing this. I was up till 3 doing that one. That one's fixed.
This one's fixed.
Yeah. So that one's fixed. Okay, so somebody should probably drive me home, but Does that help? It's making more sense this time around. Okay. All right. Oh, let's go to this guy. Let's get this big enough for you to actually see it. Okay, what do you think? It's not bad, right?
Yeah.
I don't see calculus. What do you think of the bone levels?
Or
Lower anterior.
So how much is biologic width? 1 to 2 millimeters.
1 to 2.
That's great.
I'm pretty happy. I wish mine looked that good right now, actually. The cracked tooth is not helping. What do you think of the tissue? Pretty, right?
Okay.
Full racial pigmentation. Generally, though, not red. Pretty knife-edged. Papilla actually fill the spaces, unlike mine. All that good stuff. Happy?
Yes.
So, Cal?
No.
No Cal. Bleeding?
Slight.
Very slight, right?
Okay.
Couple of pieces, a couple of spots. Is it more than 10% of the teeth?
No.
Diagnosis?
Healthy.
Healthy, therefore treatment is prophy. Right, so this is what I like about the new system. Healthy equals prophy. Healthy but reduced periodontium. Periomaintenance.
Yes, sir.
Generalized gingivitis.
Oh. Generalized.
Scaling in the presence of generalized moderate to severe inflammation.
Oh. Okay.
Okay, no cal, right? Just inflammation. So gingivitis. Stage 1, 2, 3, 4.
SRP.
SRP. Healthy but reduced periodontium. Perimaintenance. Okay, so I love how that flows straight across. Okay, this was the scary patient who was freaking out and late to their appointment, and they gave themselves their insulin and didn't eat. Remember that? Okay, so, but happy periodontally. It's just the, let's feed her and make sure they're okay, and you cannot drive until your blood sugar is normal. Stay there. Okay.
What's COE again?
That would be comprehensive oral exam. Okay. How are we doing? Oh. I know. Okay. So, take a look. This is 2 years ago we root planed this patient. Why did we root plane?
It's a lot going on.
A lot of bone loss.
How much bone loss?
I would say generalized.
Generalized?
So greater than 30%.
Is it greater than 30% of the root distance? No. Is it greater than 15% of the root distance?
We have some furcation involved.
We got some furcations. Okay. So remember on your list it says if they have furcations, it could bounce them up to the next stage. So their furcations, they have pretty short root trunks. So they have some furcation involvement even though they do not have a lot of cal. Right, so we dove in there, we root planed, they have some calculus. It wasn't like ginormous chunks, but we need to get in there. So this is the root planing day. This is now, 2 years later. Tissue's normal color, firm with slightly blunted papilla. What do you think?
Yeah, a lot more.
Okay, here's your data from the root planing. So here's your cal. What's our reliable thing for telling me what's getting worse? Cal, right? Not pocket depth, but cal.
Okay.
Here's after. Okay.
What is it about? Yeah, it's about the same.
Okay, so what's your diagnosis? Healthy but reduced. Okay, so what's your treatment plan? And how often you want to see them?
3 to 4 months.
Okay, so you can look through that. That has a health history thing in there. Let's see. Can I get through?
Let's do a few more.
Here's one you're going to want to see for sure. Oh, not that one. That one's kind of running the mill. Oh, did I not get this patient in?
No, we'll talk about
Oh, well, we'll look at this one really quick.
Whoa, that's cool.
Okay, I'm just going to have you look at these pictures. Does that scream out to you?
Yes.
That's a slap your mama.
Curio case?
Right? Do we maybe have a fairly high caries rate? I'm thinking.
Possibly.
Right? So you got a lot to say about that. Okay, sorry, let me just find one more picture that I really want you to see. I thought I got it in here. Not it. Okay, let me go back here where it said.
What is it? What are you doing? Oh, you going out? Going out. Tomorrow we just have
More class repetition.
we're our laptops.
Do we just get versions?
But our laptops are so nice. I don't want to get dirty. There's
Can
nothing.
I grab a gown from up there?
Yeah.
Yeah, I know, but.
Oh, just get one of those purple gowns?
Yeah.
Or the, yeah.
The regular, just like go
Clinic. They clean it anyways, so.
But you didn't hear from me. I'll just bring you some good stuff. Get my hair done.
What? Check my phone.
Oh, I don't think there's trays.
Was it case of dental material?
Oh.
Okay, here it is.
Because
Yeah.
All right, ready?
Oh,
Like you said, they're ready to fall off.
Where's that implant coming out?
That is a not really well done implant, but I have to say, kudos for trying with that little bone, right? Okay. So that's a not at all attractive implant, unfortunately.
In the nose.
Okay. So limited tissue to work with. Not super excited about that result. Fortunately, the patient does not have a very high smile line.
That's 10 years ago at the
So 10 years ago. Okay. What's this little bar right here? That's holding the teeth in. They are glued together across basically a big old heavy duty fixed retainer. Okay? All right, that's 10 years ago. Ready?
like a dentures.
Wait, is this for real?
This is for real.
That's
She moved. She's one of our patients.
Wait, for dental hygiene?
Uh-huh.
Oh, so one of us saw her?
Many of you saw her over the 10 plus years.
Oh, yeah.
I actually have a question about that. So for these type of patients, because I was going to do one of these patients, so I was scared I would scale and they would flick off.
Right. So have teeth fallen out when I was scaling them? Yes. Did we tell them before it would likely happen? Yes. Ms. Lee's been, at a, yes. I worked for a periodontist before we did implants that I would be holding these teeth in. Okay, but here's the thing. This patient, obviously horrifying periodontal disease. What stage would this be? 4, right? No question in your mind. You're saying this lady's going to be sucking things through a straw, right? There will be dentures.
She can't eat any apples.
Don't eat apples, right? However, this is why you don't give up.
Yeah.
Because this patient took, that was her new religion, was flossing. Right? And then flossing obviously didn't work for long. She uses every periodontal aid known to man, woman, or child. And her own resistance was good enough to arrest this. In addition to awesome hygiene with us, right? So we kept everything very clean for her, and these are really hard to keep clean. So yes, there was mostly supragingival calculus every time, because just trying to reach down in there to get it clean is hard. But this has been stable for over 10 years. Obviously unusual, but it can happen. So don't have the patient that comes in and looks horrifying, don't throw your hands up. I remember a patient I saw that had been off and on as far as coming in, and they only had 8 teeth left, right? And so I said, this can't happen. These precious 8 teeth, we're going to keep them if you're with me. And he's like, well, nobody ever told me I had periodontal disease. This happened to my dad too, by the way. You know, the man with a bachelor's, 2 masters, and an EDD. Nobody ever took 5 minutes to explain to him what was happening in his mouth. Yeah. So, 92 does not have all of them, but has most of them still. So, this patient, and the patient I had in my office, oral hygiene instruction, they pulled it together, and their body was able to respond. So, I did half the teeth one time for anesthesia for this guy, and by the time he came back the next week, this side was visibly healed. Like the tissue had shrunk down, was tight, it was turning pink. It was not bleeding much at all anymore. And by the time the 4 to 6 weeks rolled around, he looked fantastic. Did he have a lot of bone loss like this? Yes. But single-rooted teeth will amaze you with how you can hang in there. Okay? Don't give up. You know, lots of times this is going to be a losing proposition. You can't keep them. But because of the splint and because of this patient's ability of their body to respond and because of their commitment to be with us and take care of themselves at home, you can do this.
So if we have a case like this and the patient is able to stabilize the progression, but they don't like the appearance of it, and
that's the hard part.
Like I know we show like
she's willing to go with this because it functions. Is it pretty? No. But she doesn't have a very high smile line, and you don't see all of this.
Bro, where are you going?
If she was a real dummy kind of smiler, this would be more perfect. Thank you so much. You did great. So don't be overwhelmed, but do review everything. And if you have questions, get with your instructor. Every single time that you do your case presentation, be thinking, do I have this all filled out? Do I understand all parts of it? So that when I get that pretend patient that's for me, I'll understand it. Thank you.
Thank you.
So which one of these this is the old. Sorry. This is So, I take it back, sorry. Okay.